So, being the last batsman for the day, I'd like to keep it really short. I'd like to thank Dr. Vijay for inviting me for this talk. So, esophageal cancer, most of the times what we are seeing is the gastroenterologists, they do diagnose, and way to take it from there is a MDT-based approach. So, I think everyone in the hall agrees that we are seeing more of esophageal cancer cases. And this slide was shown again and again. So this is from the ESMO guidelines for the esophageal squamous cell cancer. So for those patients with early disease, it's only surgery. But how many patients are going for this surgery is a debatable thing, and how many are being diagnosed. So I think we had one patient who was with the T1C, and he was suggested to undergo total esophectomy, for which he went from here to Japan and got it done. So these are the cases where still we have a lack of expertise. They went around the city. So this is one set of patients who don't need any role of radiation or adjuvant systemic therapy, especially when they're diagnosed in this early stage. And all this, what we're discussing, the cross trial, preoperative, everything is for those with T2 and beyond. So what we do, it's as simple as that the evidence is with concurrent chemoradiation. And for those who have received this concurrent chemoradiation, we see whether they're going for surgery, and if at all surgery, based on the residual disease, we decide what to do. And for adenocarcinoma, we treat as a gastric cancer. So squamous is different, adenocarcinoma is different. For adenocarcinoma, we go with preoperative chemotherapy most of the times. If the patient, if the lesion is high up, and probably we'll go for pre-op chemoradiation, again we should plan for surgery. One area where probably we are having a lot of conversions is conversion therapy, is what we call, when we have these cervical esophageal lesions which are medically inoperable and they will be refusing surgery. We have evidence, this is from the Dutch cross trial, which is not game changing now, it was a changer earlier. And what really changed is with the immunotherapy, the Checkmate 577. So this was a 10-year-old data from the cross trial. We can see that compared to surgery alone, medical oncologists and radiation oncologists did a better job, and we can see that we improved the overall survival. And this was again confirmed on the 10-year overall survival. And if you can see the histology, squamous cell did very much better compared to the adenocarcinoma. And how do you define the resectability? So this is most of the times a debatable thing. So whenever we have a T4 tumor, when it involves the tracheobronchial tree or invades the aorta more than 90 degrees, we need to go for neo-adjuvant chemotherapy radiation and see whether we can convert them for surgery. And radiation therapy, I think this was already discussed by the radiation oncologist. So what is going to be in the future is probably whether we can have a proton beam therapy to have less radiation toxicity to the surrounding tissues. And that's a PROTECT trial which is awaited, so we'll be awaiting for the trial. And there is some data for neo-adjuvant chemotherapy even in those with squamous cell carcinoma, and see whether we can do organ preservation like we are doing in the rectum. And this is the organ preservation SANO trial, which was shown that 12% were having organ preservation without surgery. And most of the times once we do the chemotherapy and radiation, how do we predict the response, whether the patient had a really good response, and what do we do if there is a residual disease? These are questions which were always taught. So we have various tests. We are doing the FDG PET to see the response, and PET with a combined CT scan or endoscopic ultrasound, and most of the times with the histopathology. So all this will be helpful in assessing whether the patient has got a CR or not post surgery. And this is the game changer evidence which I was asked to talk about actually. So this is a Checkmate 577 where immunotherapy with Nivolumab was given compared to placebo for those patients who received chemotherapy radiation. And we can see that the curves, the final conclusion was that it showed doubling of the overall survival compared to placebo for those who received adjuvant Nivolumab. So game changer is to give Nivolumab post chemotherapy and radiation. And we also have other game changer immunotherapy drugs in advanced esophageal cancer. So we can see across all the trials, there is widening of the curves with immunotherapy compared to placebo. So whether you are going with the immunotherapy like pembrolizumab or nivolumab or toripalimab, all of them have showed significant benefit in survivals when they were given with or without immunotherapy. And for those with high PD-1, pembrolizumab is a drug which has shown great benefit. For those with only 1% or more, nivolumab or nivo-IP without chemotherapy can also be given. And for those with low, we can give nivolumab for all comers. And this is something new which is not especially in esophagus, but for those with adenocarcinoma, claudin 18.2 is a target which is being tried in a CAR T cell therapy. So this is a phase 2 trial which is being studied in China. So we can see promising results with the CAR T cell therapy with the claudin 18 receptor. So this is something which we'll be looking forward in the phase 3 trial. And the conclusion was that this is quite safe and this can be tried out in the future. And the last one is the role of ctDNA. I think we have now the ctDNA available as Guardant Reveal for 2.4 lakhs for colon cancer. So whether we will be using that post-chemotherapy radiation to see whether we'll be going for surgery or not, this is again another point where we'll be studying. So this is those patients who have the circulating tumor DNA detected on the blood have poor survival. And to conclude, for all those patients with early stage, it's only surgery. For those beyond T2 and above, it's chemotherapy and radiation followed by surgery, followed by adjuvant immunotherapy. Adenocarcinomas, you can go ahead with the cross protocol or with the float chemotherapy. And for those for advanced esophageal cancer, immunotherapy is something which we are doing almost for all patients who have PD-1 high with pembrolizumab, and anyone with at least one or more, we are giving the nivolumab. And early tumor, it's surgery. Endoscopic surgery, as I said, is still on the learning curve with us. And for those with locally advanced tumor, most of the times it's a combined decision making with the team, and neo-adjuvant chemotherapy radiation with surgery and immunotherapy. And future directions is with the proton or induction chemotherapy, and giving immunotherapy in the neo-adjuvant setting also. Thanks all. Thanks, Dr. Vijay.